Yeah, preparing to go live on YouTube.
Okay, awesome. So now this will be like the same way that we do our Thursday and Fridays, where instead of recording it, we are streaming it live to YouTube. Okay. Right.
All right. Awesome.
You're doing that just in case.
Yeah.
Okay.
Yeah.
All right, guys. Happy Monday. Thanks for joining us for our regular Monday, either product or health topic Zoom. Today we're discussing Mr. Glinsky himself. Today we're discussing a health topic, and it's called sarcopenic obesity. And the main reason why I wanted to talk about this is because a lot of people don't know about it, and it's really not diagnosed.
But it's super common.
Right.
And let's just go ahead with the definition of sarcopenia.
Okay. Well, sarcopenia is defined as a low skeletal muscle mass. Okay. We know what obesity is, right? Defined as high body fat percentage. So sarcopenic obesity is the combination of obesity, so the high body fat, and the sarcopenia, the low skeletal muscle mass. Mm-hmm. And it's also accompanied by low muscle function. Mm-hmm. So it needs to really be considered a unique condition, right? Different than obesity and sarcopenia alone. And the prevalence of it among adults is rapidly increasing worldwide. Didn't you say you were reading something like 1/3?
So no, my preparation for this, Lisa, was strictly sarcopenia. I didn't realize we were talking about sarcopenic obesity, whereas sarcopenia by itself is just, it lacks the obesity component. It still has a lot of the metabolic dysfunction, which I was going to talk about, but it lacked the obesity component. Okay.
But all in all, it's important to understand all of them, because we all know what obesity is, right? We all know it's over body fat.
Yeah.
So again, pulling into the sarcopenia side,
progressive loss of muscle.
Right. So
as we age,
put those two together, and think about how high risk that really makes you. And it's actually higher risk, like I was saying, than just either one alone.
Sure.
So despite appearing to have a normal body weight, so this is very common with sarcopenia obesity. Now, you don't have to have a normal body weight. You can be overweight with sarcopenic obesity, but it's very common to be of a normal weight. So you go for your checkup in your doctor's office, and they say, oh, Susie, you're doing great. You're 135 pounds. Your BMI, body mass index, which is your height to weight ratio, is 27. Okay, you're doing good. Everything's great. But little do they know, or do you know, what is going on inside your body? Your muscle mass is way down and your fat mass is way up. So enter the metabolic risk factors, right? So the prevalence of diabetes, high blood pressure, high cholesterol. I'm sure you all know of that person that on the outside appears like everything's going well, they're very healthy. It's a misconception. We really do look at a body shape, a body size, and we put that towards that person is healthy. I know several people have had sarcopenic obesity. I actually have a client of mine that is trying very hard to get this client to be lifting more weights, more resistance training to increase that muscle mass. Very commonly though, why does the combination of the two happen? It's 100% lifestyle, but it's your lack of exercise, your lack of resistance training, and a poor diet. Or just, even if they think they're eating well, I consume so many fruits and vegetables and I eat my nuts and blah, 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 but you're not consuming enough protein, right? So therefore you're not putting on that muscle. And yeah, I mean, what else do you want to add to that?
I think just to make it more clear, sarcopenia, if you present and you go in for your checkup, I mean, it's a progressive loss of muscle as we age. So I don't know necessarily that many people are viewing it as a diagnosable disease, right? And that's unfortunate, because I think we're missing a huge chunk of what's going wrong with, like Lisa alluded to, is the start of chronic disease. Because once you're metabolically dysfunctional, I guess is a way to put it, it kind of adds fuel to the fire for cancer, for diabetes, for cardiovascular disease,
early mortality,
neurodegenerative diseases like Alzheimer's and Parkinson's for sure. And there's a lot of different ways to sort of say, like, if you go in at about 50% of people of age 80 are, say, sarcopenic, and they consider that normal, but that's actually not normal. And so we've normalized this sarcopenia, this progressive loss of muscle mass as we age, it's going to completely normalize to where we really don't do anything about it. We're not being proactive. We're not talking to people, because it starts obviously in our earlier years. We're talking, if you're 80 and you're 50%, that's whatever, but it starts in our 30s and 40s and our 50s.
Right. And we talked about that before, how you start to lose muscle mass in your 30s. So picture by the time that you're 80, they're just like, oh, well, this is life.
Yeah, exactly.
This is what happens.
But we do know about metabolic syndrome. And that's what I was thinking about today's conversation would be. It's like, okay, there's sarcopenia, but really that's a metabolic disease state, right? Like it has a lot to do with storage of fat. And I think, Lisa, you'll probably talk about that here in a minute. But there's a lot of dysfunction going on within the body from a metabolic perspective, so cellular health level. And that is recognized in the mainstream medical, side of things. So they do recognize it, but they really don't do a whole lot about it. And the testing to determine it is tricky. So there's a lot of stuff that hopefully today, the point of the message is that we want to create an awareness around this, and we want to create a call to action. And so why don't we just keep going with definitions?
So it's more though, like to where Ryan's saying call to action, we want you to address this. So when you go to your doctor's office and they just put you on a scale and measure your height and your weight, maybe it calculates the BMI right there because it's just based on height and weight. That's just not enough. And more doctors that focus on lifestyle medicine are starting to have different types of measurements in their offices. So BIA, bioelectrical impedance. So that can show you the breakdown of the percentage of your fat mass versus muscle mass. And of course, these have, there's room for error. They all have a little bit of error, but you still can see these numbers, and you can still, now you have a goal, right? Oh, your fat mass is 35%, so we know that we want to start to convert that. We want to bring that fat mass down and bring that muscle mass up. So the next time you have your doctor appointment, you have numbers to go by. You're not just kind of guessing on what's going on inside, because again, and I keep bringing up of somebody that's of normal size, because that's where it goes most hidden, because on the outside, everything appears to be nice and healthy. And then also when that goes on, your blood work shows, oh, Susie, now you've got high cholesterol and your blood pressure's creeping up. So we're going to give you some medications for that, but nobody's addressing the underlying issue. Why does Susie look so good on the outside, but now all these things metabolically are going wrong on the inside? Nobody's addressing that. We talk about the root cause. What's going on here? Well, she just needs to do lifestyle changes, increase that muscle mass, decrease that fat mass. And we talk about all the lifestyle changes: diet, exercise, supplementation, sleep's
huge on this one.
Yeah. So it all goes hand in hand.
Stress. Yep.
I don't know if anybody's heard, as I'm talking about the one of normal size that's still metabolically, things are not going well inside. Have you ever heard the term skinny fat? But if you're not, that's kind of like a loose term that's just thrown out there when somebody on the outside appears to look good, their body shape is great, their weight is great, but inside really what's going on is not good.
Sure.
There's an analogy. I was telling Ryan this analogy. He's saying it might be more confusing, but I'm going to go for it. I'm going to try it. Sure. So think of it as a bathtub. Each body has its own bathtub. So the smaller the body, the smaller the bathtub.
For storage of subcutaneous fat.
Storage of fat.
The bathtub is the storage of subcutaneous fat, which is our healthy fat that hangs on our skin that you can pinch and squeeze. That's the stuff that is good for energy. That's the stuff that our bodies need.
We might not like the way it looks, but a little bit of it is very important.
Right.
Yeah.
So that's your bathtub.
So our bathtub has the storage for this fat. So a smaller body obviously is a smaller bathtub and can store less fat. So then all that fat starts accumulating in that small bathtub. And eventually what happens when you fill a bathtub too much, it overflows. And now where is all that subcutaneous fat going to go now? It's going to go around our organs. It's going to turn into the visceral fat. And that also is a measurement that these BIA scales can tell. They can actually break down your visceral fat. What's going on around your organs, guys? That's the stuff you really need to worry about. So that's why, again, you don't see it. Okay, we don't see the visceral fat, and that's why I want you to understand how important it is, and how the scale, the number on that scale, is not that important, because you could take a 200 or 300 pound body that has a bigger bathtub. So they're very big. They're carrying a lot of fat. You visually see the fat, but that bathtub is holding the fat. So they have a lot of subcutaneous fat. So aesthetically, they look big and fat, but versus, I mean, the body that I just said with a smaller bathtub that's now overflowed to the visceral fat, that's the one that is more unhealthy. That's the one that is higher risk for your metabolic disorders.
Yeah, and then I'm going to clear something up here. The bioelectrical impedance that she's referring to is just a souped up scale. If you've seen one, it's one of those things where you get on, usually you hold a handle and it uses electrical current to tell you your relative percentage of body fat to lean muscle mass. So that's what she's referring to. That's one probably more mainstream way. And definitely a tried and true way to do it is also a DEXA scan. I don't know that many practices are using that. I don't know how practical it really is. But again, the bioimpedance analysis is really a good first step to figure out those numbers.
Yes, and they do make, affordable scales, BIA scales on Amazon.
Yep.
I mean, they're really not that much. Again, there's gonna be percent error, especially for just, not buying one for a doctor's office. We're just getting one online.
Right.
But you still, again, have numbers, okay? And you'll be able to tell if your fat mass is a little high and your muscle mass is a little low. And that's your guide. Okay, here, I'm gonna start doing lifestyle changes and I'm gonna watch that conversion go, right? Again, lifestyle changes. Lifting weights, resistance training, get some bands, use things that you have in your home, body weight stuff, whatever it is that can help increase muscle mass, consuming adequate protein. Here comes our LiveGood supplements in the hand. Okay, what we have here are things that are going to help you put on that muscle. Okay, 20 grams of protein in 1 scoop of our protein powder. We are under consuming protein. It's very hard to get the right amount of protein that your body needs without over consuming calories. 106 calories in this, guys. So this is a very easy way. Essential amino acids are building blocks of protein. And then our collagen peptides, not only do they do so many other things in the body, but just showing you here, I mean, there's an additional 10 grams of protein. Put those together 1 to 2 times a day, you've really helped your body start the process to help build and maintain that muscle mass.
Yeah, and I think too, I wanted to go back to the testing, how people can go in and if you see your doctor, how you can ask for things. Most people that are metabolically unhealthy are insulin resistant, potentially have already shown signs of diabetes. So you really want to get in there and get your A1C down, which is your 3-month average, your blood sugar. You want to know your insulin levels. And I don't know why most practices don't do it. I know it's not fun, but an oral glucose tolerance test is a great, more reliable way to determine how your body is responding to a sugar load. So these are the things that you really want to get your hands around. You really want to understand these numbers, but at least get in, at least get your lab work done, get on a bioimpedance scale. If the doctor doesn't have it, encourage them to get one. I agree with Lisa. I don't look at a scale number. I don't look at BMI. I'm obese according to a BMI just because of the density of my, I guess just that's the density of my muscle mass. But that's the point though. We don't want you to just get stuck in that rut. And it's like, this is information that we can use. This is very useful,
right? Actionable
data.
Be your own advocate for your own health. Like you've got to take charge and don't just, because again, in a doctor's office, we typically have a regular scale and to measure your height. So you need to plug things, you need to ask questions, and you need to do your own research on where you can find a facility that will perform one of these tests for you.
Yeah.
Super important.
And I wanted to just also add to what you were saying about when body fat spills over. So that subcutaneous is healthy fat, uses energy. We need it. Healthy percentages you can search online and see. I think men is 10 to 20, women's 20 to 30% body fat. But that depends on your age, depends on your fitness level, a lot of different things. But when your body starts to accumulate more fat and it spills over, and we call that visceral adipose tissue, that's the stuff that's clogging around your organs. And that's the stuff that's causing so many of our hormonal fluctuations and dysfunction. That's a big contributor to that. And especially the inflammation. So there's a lot of problems there. And there was one study I was looking at, but they were talking about how they removed liposuction, but you only really pull out subcutaneous fat. So these people dropped a whole bunch of weight,
sure,
but didn't touch the visceral adipose
all
tissue.
Aesthetics.
Yeah, and their metabolic numbers never changed. They were still just as sick as ever. So that's the stuff that we really need to be very, very careful about, because again, that's the fuel. That's the stuff that fires and sends it's into cancer, neurodegenerative diseases, Alzheimer's, Parkinson's, diabetes, hypertension. So we've got to be very, very aware of the reality of that. And the corrections aren't anything that extreme. Like Lisa said, it's supplemental, it's stress, it's sleep, and it's also some exercise, some load bearing, some movement, some aerobic stuff. Nothing too complicated, nothing too hard, and anybody can do it. So that's what we're encouraging you guys to do today.
Yeah, 100%.
Yeah.
Someone's just asking here about how much protein is recommended per day. For example, this person here is 160 pounds.
Yep.
I mean, my rule of thumb is 1 gram of protein per pound of body weight. The RDA is much lower, and it's really being recognized now that that is not enough. So the RDA is 0.8 grams of protein per kilogram of body weight. Okay, so it's much lower than the 1 gram per 1 pound. So for 160 pounds, that would be 160 grams of protein. And again, really hard to do. If you think about your 3 meals a day, average with meat, 20-ish something grams of protein, think about all the other leftover protein that you still need. That's where this comes into play. It's super helpful. I rely on our protein powder so much to help me reach my protein goals.
I would never suggest somebody go hard to that goal, though. I think you should titrate up, work your way to that gram per pound.
Yeah, little by little.
Because if you're not there now and you just decide to go do that, that's not necessarily a good idea either. So work your way up to it.
Right. So say you're eating 60 grams of protein a day, little by little, add 5 to 10 more, and just let your body acclimate to what you're introducing to it. So that goes with anything, right? We try not to bombard the system, let the body adapt as it should.
Sure.
So just remember, it's not your body weight or your shape that really matters, guys. It's your muscle mass and your fat mass. It's what's going on inside that body. So think about that skinny fat. We don't want to have that. We don't want obesity. We don't want to be sarcopenic, and we definitely don't want sarcopenic obesity. So,
yeah, there we go.
Yeah. Any other questions on this topic? Please feel free to email me.
All right.